Hello and welcome everyone. The topic for the lecture is IgA nephropathy, and IgA nephropathy is also known as Berger's disease, and it is the most common cause of glomerulonephritis worldwide. Now the important feature being that there are IgA deposits in the mesangium of the glomerulus. So there is another condition where the IgA deposits they are seen in the mesangium, which is Enoch-Schonlein purpura. So in HSP also similar deposits are seen, but in HSP there are systemic manifestations as well. So patient can have generally it is a child, and in children the skin purpuric rash they will be seen, abdominal pain, intestinal bleeding, arthralgias, and along with that IgA deposits in mesangium is seen in HSP. So HSP differs from IgA nephropathy that systemic manifestations are also seen in HSP, but both are considered to be manifestation of the same disease. So you should remember these points for this IgA nephropathy and HSP. Now second important point is the recurrent and gross hematuria, which is seen in case of IgA nephropathy. It is a very important clinical feature. There is hematuria which is grossly visible in the urine, and also it is recurrent. It subsides and then again recurs. Clinically, there is mild proteinuria. It can manifest as nephrotic syndrome. As you can recall that in the causes of nephrotic syndrome we have studied IgA nephropathy as well. Then it can also present as an acute nephritic syndrome, and it can have hematuria and proteinuria as well, and it can progress to crescentic glomerulonephritis or rapidly progressive glomerulonephritis. Again, you can recall that in type 2 RPGN we have read IgA nephropathy as a cause. Now it is the again MCQ most common cause of recurrent gross hematuria, and the causes of IgA nephropathy can be hereditary or acquired. So in acquired causes there can be various infections, and infections of the respiratory tract, GI tract, the genitourinary tract due to various viruses, bacteria, and then these IgA, they are especially the polymeric forms, they are degraded by the liver. So in case of liver disease there can be secondary IgA nephropathy. Also in celiac disease, due to certain autoimmune mechanisms, there is prevalence of IgA nephropathy. So you have to remember these important causes. Now in the pathogenesis there is multi-hit etiology, and several steps they are involved in causing this IgA nephropathy. And you know that IgA is a immunoglobulin A, and it is second most common immunoglobulin after IgG, and mostly it is seen in the body secretions like secretions of the GI tract, and it is less seen in serum but more seen in the body secretions. And there are two forms, one is monomeric form and the polymeric form. So in the polymeric form which is generally degraded by the liver, so if there is liver disease then it can get deposited, and most commonly it gets deposited as the IgA1. So this is the form which most commonly gets deposited. So what is the basic pathogenetic mechanisms? So due to the various hereditary and acquired causes, there is defect in the glycosylation of IgA molecule, and in the hinge region of the IgA, specifically IgA1 molecule, there is defect in the attachment of the galactose. So these galactose deficient IgA molecules, they have the property of eliciting a immune response in the body. So they are recognized as foreign molecules by the body, and antibodies are formed against these. So this galactose deficient IgA1, it acts as an antigen, and IgG antibodies are mounted against them. These antigens, they can directly get planted in the mesangium, and in situ immune complexes can later be formed, or they can be formation of circulating immune complexes with IgA1 and IgG, and these complexes then later on they can get deposited in the kidney. And when these deposits they get deposited in the mesangium, then that will lead to glomerular injury due to various mechanisms like complement activation, then leukocyte infiltration, cytokine secretion. So and all these will lead to the glomerular injury. They will be glomerular injury followed by healing with fibrosis, and repeated cycles can over a long period of time lead to chronic kidney disease or even end stage renal disease. So let's go into a bit details of the pathogenesis. So there are various hereditary and acquired defects, and these defects will cause the defective glucosylation of IgA1, and because of that they will be recognized as foreign antigen by the body, and it will mount an autoimmune response. These IgG autoantibodies are formed, and then they will form the immune complexes in the circulation. Alternately, these IgA1 molecules can get deposited in the mesangium. In the mesangium, there are these transferrin receptors known as CD71, and there, when this IgA1 reaches the mesangium, then IgG can get attached to it to form in situ immune complexes. So immune complexes can be circulating as well as in situ. So ultimately they get deposited in the mesangium. After they get deposited in the mesangium, what they will cause the activation of the mesangial cells, and mesangial cells will cause the increased synthesis of extracellular matrix. These cells, they will proliferate, and they will also secrete cytokines and various growth factors, and there will be activation of the alternate complement pathway because of these immune complexes. And because of these, the deposits in the mesangium, they have C3, and they don't have C1q and C4, which are the part of the classical pathway of complement. So C3 will be present, and all these because of these factors, these cytokines, they will recruit the inflammatory cells, the leukocytes, and all this will cause the glomerular injury. So this is how this IgA molecules will cause the injury to the glomerulus and ultimately the deterioration in the renal function. Now for the diagnosis, most important is the renal biopsy. In the renal biopsy, we stain the tissue with H&E, and we see the features. So there is mesangioproliferative glomerulonephritis. So there is proliferation of the mesangium. So mesangiums will appear with increased cellularity, and also there is endocapillary proliferation. The mesangial cells, they synthesize the extracellular matrix, so that is increased. We can see there is increase in the mesangial matrix. Then WBCs may be seen, and rarely they can be crescent formation. And focally, the sclerosis can also be seen. When the lesions are healing, then there will be sclerosis. So focal sclerosis, and later on even crescent formation can be seen. Now in the immunofluorescence, we try to detect the composition of these immune complexes, and they are composed of IgA with complement, and the complement is mainly C3 and properdin because of the activation of the alternate pathway of complement. And then in electron microscopy, there will be electron dense deposits in the mesangium. So the deposits can be located as present in the mesangium by the electron microscopy. Other important investigation will be the blood investigations, the blood urea nitrogen, the renal function test, blood urea nitrogen, creatinine, etc. can be estimated. Then urine examination can be done to demonstrate the proteinuria, hematuria. So these are the important points in the diagnosis of IgA nephropathy. And lastly, clinically, the disease is seen in children and the young adults. There is a history of infection, so this can be given in the problem-based question of IgA nephropathy. There can be a respiratory tract infection or gastrointestinal infection or genitourinary infection, which will be present in a short duration, like 1 to 4 days back. The patient will give a history of this infection. So this you have to remember. Then clinically, there will be hematuria with or without proteinuria. In 5 to 10% of patients, there is presentation as acute nephritic syndrome. So there will be proteinuria, hematuria, and later on it can also progress to rapidly progressive glomerulonephritis, or can present as crescentic glomerulonephritis. Now hematuria is recurrent, so it can occur again after a few months. It is a characteristic feature of IgA nephropathy. Then chronic renal failure will be seen in about 15 to 40% cases over a long period of time, which is spanning over 20 years. Now the risk of progression to the end-stage renal disease, it is seen more if the disease onset is in old age. Usually affects children, young adults, but if onset is in old age, it has got a increased risk of progression. Then if there is heavy proteinuria, usually mild proteinuria is, but heavy proteinuria associated with progression of the disease. Then hypertension and glomerulosclerosis. In the treatment, we give steroids, immunosuppressants since it is as an autoimmune etiology, then renal transplant, and recurrence after renal transplant is also common. ACE inhibitors and angiotensin receptor blockers are used for the associated hypertension. So one more point, that the history of infection is also seen in case of PSGN, post-streptococcal glomerulonephritis, but in that the history is about 10 to 14 days. But here the history will be short. Also, the complement levels, they are decreased in case of PSGN, while here they are normal. So thank you very much. And any questions, they are most welcome in the comment section.